Hi everyone, I'm Nidhi Madan. I'm a structural interventional cardiologist in Omaha, Nebraska, and I also work with the FiRST Committee at SCCT. I am joined by my colleague at the FiRST Committee, Dr. Patricia Rodriguez Lozano today, who is an advanced cardiac imager at University of Virginia. And we have the pleasure of talking to Dr. Renee Bullock-Palmer, who will be telling us more about cardiac imaging in women, chest pain guidelines. Stay tuned. I will be handing over to Patricia here, and she will move the conversation along.
Thank you, Dr. Bullock-Palmer, to be here. Dr. Palmer, as we know, she's the director of the Non-Invasive Cardiac Imaging and Women Heart Center at the Deborah Heart and Lung Center in New Jersey. And she's also the governor-elect of New Jersey chapter of the American College of Cardiology and a transformational leader. So today we're going to talk about imaging coronary disease in women, and then I want to start the conversation, Dr. Renee Palmer Bullock, about what is the role of CCTA in evaluating coronary disease in women.
Great. So coronary CT plays a key role in the diagnosis of CAD in women. As we know, women, do have, a greater prevalence of non-obstructive coronary artery disease. And, the value of CT is that we're able to diagnose the full spectrum of coronary artery disease, not just obstructive coronary artery disease, but even non-obstructive plaque. And I think CTA is valuable for women in that regard. And in terms of, looking at all the imaging modalities, it's very important that we also consider, not just looking at, once we've looked at the anatomy, but also looking at the perfusion and function and even looking for microvascular disease, which we'll get into a little bit later.
That is so important.
And on that note, Dr. Palmer, how do you assess clinically what is the clinical assessment for women in particular when it comes to coronary artery disease, and where do we stand with microvascular disease?
Right. So in the guidelines, one of the things that we tried to do was to make sure that we focus on the fact that women are just as likely as men to present with chest pain. It's oftentimes misperception that women do not present with chest pain, but they in fact do. But what in the midst of their presentation, in addition to chest pain, they'll have other symptoms like shortness of breath, fatigue, and sometimes they may play on those symptoms more when they present to you. One of the things I try to do when I have my patients present to me in the office is that, I do not really ask, do you have chest pain? I say, do you have any chest sensation? Because they'll say, no, I don't have any chest pain. And then 5 minutes into the conversation, oh, I do have some chest tightness, chest pressure. And that's, one of the key features of heart disease, as we know. So really, teasing out the history and getting that from them. And then once you get the history, assessing their pretest probability. What are their risk factors? Have they had any preterm deliveries? Have they had preeclampsia pregnancy? Those are some of the things, lupus, rheumatoid arthritis. So once you've had their pretest probability, then one of the next steps is that, is this someone that is low risk, intermediate risk, high risk? In the guidelines, even for the low risk woman, one of the things that we tried to do was use coronary calcium to further refine these women's risk. We had a really great session yesterday on prevention and heart disease. And the value of that is that if this patient is presenting to you with chest pain and a calcium score of 1,000, you know that that patient is high risk, and you know that that patient needs to be studied. As opposed to if it's a low risk female and their calcium score is 0, then it's probably not as risk, high risk as you're thinking. So using that to refine the risk, then looking at the intermediate risk women, functional testing, particularly, once you've, had them presenting, looking for microvascular disease. One of the things that we did with the guidelines was to really give prominence to cardiac PET as being, and cardiac MRI as being valuable in assessing microvascular disease, because that's oftentimes misdiagnosed, underdiagnosed. So those are some of the things that we used in the guidelines to try and really approach, diagnosing women with chest pain.
Talking about the guidelines, tell us what is your opinion about the guidelines addressing this issue about women. Do you think they serve well women in the guidelines? Not only our 2021 chest pain guidelines, but what about the international guidelines?
Right, so we had a great session on Friday that looked at international guidelines, the ESC guidelines, and NICE guidelines. And I think, with the ESC, they also had looked at pre-test scoring and probability So those are a little bit similar, I think, to the US guidelines. The NICE guidelines, as we know, really focused on anatomic imaging. They really threw pretest scoring out the window and really focused on CT. One of the things that we have to remember is that there's a universal medical system in terms of coverage, insurance coverage in the UK as opposed to the US, where it's all privatized. It's not really government insured. So I think one of the challenges is that we would all like to have CT at all institutions in the US, but unfortunately that's not the case. So having that strategy similar to the NICE guidelines, I think would be very challenging in our situation. So I think those are some of the things that we discussed, at that session. Of course, when you have multiple players at the table putting together a guideline, it's not easy. You have to serve many masters, and everyone wants to play nice, and sometimes, at the same time, though, you want to make sure that the guidelines that you're writing is based and founded in science. I mean, some people might be offended by that, but that's just the reality, and I think that's important to remember.
What would you say your takeaways are, since we are at SCCT 2023? What would be your takeaways from this meeting? So my takeaways is that I really liked the fact that congenital heart disease is playing a major role in the meeting. I'm seeing a lot more sessions on congenital heart disease. We had a really great session yesterday morning at 10:30 that spoke about practical use of CT for congenital heart disease, and not the reason I said congenital heart disease and not ACHD because there were actually pediatric imagers there as well, in addition to adult imagers. So really great option, great session, and then that was followed by a town hall roundtable that Dr. Kelly Han had led, and really getting people's thoughts and ideas to see how can we expand the footprint of congenital heart disease in the society. So I was really excited about that. I was also excited about team spirit that was yesterday evening, and I'm really amazed how Dr. Stefan Achenbach had, really gets the energy in the room, and we're playing against each other, team A, team B, although we were all on team B and we lost, but that's okay.
We were very close.
Exactly, but we learned a lot from the session, and I think those were my two favorite parts of the meeting.
That's awesome.
Yeah, and thank you very much for doing this with us. I just learned a lot talking with you right now, and it's always wonderful to have these conversations with leaders in the field.
Thank you.
For sure. Thank you again.
Okay, no problem.